please like and subscribe to the show. So imagine taking your car to a mechanic because you hear a strange ticking noise.
Right.
But instead of popping the hood to investigate, the mechanic tells you they are legally barred from looking at your oil levels. They can't do any preventative maintenance at all.
Which is crazy.
Yeah, instead they just hand you a business card and say they'll, eagerly wait to rebuild your engine from scratch once it completely explodes on the highway.
Yeah, that's exactly the situation we're in.
Right, and today's mission is an in-depth exploration of the official transcripts and witness testimonies from the House Ways and Means Health Subcommittee field hearing. This was held in Bradenton, Florida. We are looking directly at the structural reality of the United States healthcare system.
Yep.
And the motivation behind this hearing is it's crucial for you to understand.
Yep.
The United States spends an astounding $5.3 trillion annually on healthcare. Yet 60% of Americans have at least one chronic disease. So the goal of the hearing is to figure out how to modernize healthcare, shift from just, managing sickness to actually preventing it, and empower you to live a healthier life.
In that mechanic analogy you mentioned, that is exactly what the committee is debating. We're operating a system engineered almost entirely for sick care.
Right. Disease management.
Exactly. The management of existing disease rather than actual health care, which is the prevention of disease.
Yeah.
You have a system that is incredibly efficient at performing a complex engine rebuild, but it completely fails at just checking the oil.
And the financial reality of waiting for that engine to explode is, frankly, staggering. During the hearing, Representative Smucker cited a Deloitte study.
Oh, yeah, the prevention numbers.
Yeah, pointing out that investing in disease prevention could cut United States medical and drug spending by $2.2 trillion a year.
That's a massive number.
It really is. To put the alternative into perspective, if the system continues on this path unaddressed, obesity alone is projected to result in $9 trillion in excess medical expenses over the coming years.
Which, brings us to why those numbers even exist in the first place. It really comes down to the fee-for-service model. The current healthcare system financially rewards procedures over prevention.
Right.
Providers are paid a fee for every specific test, every surgery, and, every pharmaceutical intervention they deploy after a patient is already sick.
After the fact.
Exactly.
Right.
Medicare, as a primary example, currently spends only 5 cents of every dollar on primary care. The structural design just does not financially reward a physician for keeping you out of the hospital. It rewards the hospital for treating you once you're already admitted to the emergency room.
Okay, let's unpack this financial misalignment of the fee-for-service model. Because Dr. Stelios Rickus, who's a bariatric surgeon who testified, he brought up an excellent comparison to auto insurance.
I really like this point.
Yeah, it makes so much sense. If you go years without a car wreck, you are categorized as a safe driver and your insurance premiums drop. You are financially incentivized to maintain safe driving habits. So why doesn't the healthcare system incentivize you in the exact same way?
Right. It doesn't at all.
No. If you actively participate in your preventative screenings, or if you proactively take the time to see a dietitian to manage your nutrition, there is no structural financial reward for you. In fact, you often have to fight your insurance company just to get that dietitian visit covered.
Yeah, you would think this system would want to avoid massive payouts by encouraging those cheap preventative steps, but the math actually works backward in this system.
It's totally backward.
And that leads to severe unintended consequences. Dr. Christopher Davis, who's an interventional cardiologist, he provided a perfect example of this disconnect in his testimony.
Right, the vascular procedure.
Yeah. Under the current fee-for-service structure, providers are paid roughly $15,000 to perform a peripheral vascular procedure, basically to clear a blocked artery in a patient's leg.
Okay.
The system eagerly pays that $15,000. However, insurance will routinely refuse to cover a basic environmental toxin test that costs a tiny, tiny fraction of that amount.
Which is incredibly frustrating.
Exactly. Because that test could identify the underlying issues causing the arterial damage before the blockage even occurs. We pay a massive premium to fix the catastrophic damage, but we completely refuse to pay pennies on the dollar to measure the risk beforehand.
So if the system refuses to pay for testing the root causes of our illnesses, what exactly is happening to our bodies that we are missing?
Well, yeah.
Which actually brings us to Dr. Davis's own experience.
You're right. Yes, his personal story is really telling.
Yeah, when he was just 7 years old, his appendix ruptured. He spent weeks in the hospital with tubes coming out of every orifice, just literally fighting for his life.
Right.
And that trauma inspired him to become a doctor. He went through rigorous training, became an interventional cardiologist, and achieved his dream of standing in the catheterization lab opening blocked arteries.
Hero work, basically.
Exactly. But after a decade, he noticed a really troubling pattern. The exact same patients were coming back through the revolving door of the hospital with the same chronic illnesses. He realized he was treating the consequences of a problem without ever looking at the cause.
And this realization caused him to entirely shift his focus to the biological and environmental drivers of chronic disease. He began looking really closely at environmental toxins.
Right, the stuff we're exposed to every day.
Yeah. We are talking about heavy metals like mercury and lead, agricultural chemicals like glyphosate.
Microplastics too, right?
Yes, microplastics and endocrine disruptors like PFAS, which are often called forever chemicals. Dr. Davis detailed the precise biological mechanisms at play here. When these substances enter your body, they cause oxidative stress.
Oxidative stress, okay.
Yeah, you can think of oxidative stress as essentially the rusting of your cells from the inside out. They also cause mitochondrial dysfunction. Your mitochondria are the power plants of your cells. So when toxins damage them, the cells cannot produce energy correctly, and that leads to chronic systemic inflammation.
Wow, I mean, that is intense.
It is. This unseen cellular damage is the direct biological driver of cardiovascular disease, metabolic dysfunction, and neurocognitive decline.
I want to stop for a second because that is a lot to process. If
Yeah.
these heavy metals and forever chemicals are literally rusting our cells and shutting down our cellular power plants, why aren't doctors bringing this up at every single checkup?
What's fascinating here is how the structure of a standard doctor visit actively prevents physicians from addressing these exact root causes.
How so?
Because of the way the fee-for-service model compensates clinics based on patient volume, the standard doctor visit is now squeezed into a 7 to 12-minute window.
Right. It's so fast.
In that incredibly brief block of time, it is physically impossible for a physician to have a meaningful discussion with you about your daily nutrition, your sleep physiology, your stress management, or, to investigate your potential environmental toxin exposures.
There's just no time.
Exactly.
Yeah.
Because there's absolutely no time to play detective and find the root cause, the immediate default is to write a prescription to manage the most pressing symptom.
But, the committee members kept emphasizing this idea of patients needing to step up and act as the CEO of their own health.
Right, taking personal responsibility.
Yeah, but I have to push back on that expectation slightly based on what we're discussing. How can you, or any patient, be expected to act as the CEO of your own health when you are kept entirely in the dark about the exact toxins in your environment?
That's a very fair point.
If insurance won't pay for the heavy metal testing and your doctor only has 7 minutes to speak with you before writing a prescription, you are operating a company completely blindfolded. You cannot take ownership of a biological problem you are not allowed to measure.
That is a very fair critique, and it connects directly to how we view other chronic conditions, like obesity. Dr. Reckes testified that obesity must be treated as a biological disease, not a moral failing or just a simple lack of willpower.
Right. It's a medical condition.
Yes. He pointed out the distinct differences in treatment mechanisms. Medications like GLP-1 agonists, such as semaglutide, they are incredible clinical advances that simulate fullness and produce 15 to 20% weight loss.
Right, they've been everywhere lately.
They have. But bariatric surgery actually alters the gastrointestinal anatomy, causing a profound metabolic reset. Dr. Reckes noted that surgery produces 25 to 35% more weight loss than the medications.
That's a huge difference.
It is, and it achieves significantly higher rates of long-term diabetes remission. It addresses the root metabolic dysfunction, rather than just managing the appetite downstream.
So, when you are blindfolded to these root biological causes and the system only pays for interventions after you are extremely sick, things get astronomically expensive. And who pays the price for that?
Yeah, that's the big question.
Everyone is impacted by rising healthcare premiums, but the human cost falls disproportionately on low-income earners, rural Americans, and those enrolled in the Affordable Care Act, or ACA, marketplace.
Yeah, Scott Darius, who is the executive director of Florida Voices for Health, he brought a very specific face to this systemic failure during the hearing. He shared the story of Priscilla Brown.
Right, the truck dispatcher.
Yes, she is a 48-year-old truck dispatcher from Orlando living with type 2 diabetes. She relies entirely on the ACA marketplace for her health coverage. But because of rising out-of-pocket costs and deductibles, Priscilla is forced to ration her prescribed insulin.
That is just heartbreaking.
It really is. Some days she takes half her dose or a third of her dose, risking severe diabetic complications, just so she can afford basic living necessities like food and shelter.
The financial burden is pushing working citizens to the absolute breaking point. I mean, in Florida alone, the average monthly premium for ACA marketplace enrollees jumped by 30%.
30%? That's huge.
That is a massive financial shock. But what really stood out in the hearing is the unintended consequence buried in the design of the Medicaid coverage gap.
Yeah, the math of this coverage gap is critical to understand. In a non-expansion state like Florida, Medicaid eligibility is incredibly strict. The maximum amount a single parent with 2 children can earn and still qualify for Medicaid is $8,000 a year.
$8,000 a year, that's nothing.
Right. Let's think about how that functions in the real world. If that single parent takes an extra shift at work and earns $8,001,
Just a single dollar over the limit.
just a single dollar over, they are completely stripped of their Medicaid coverage. However, they do not earn enough to reach the federal poverty line, which is the minimum threshold to qualify for the tax credits that make the ACA marketplace affordable.
So they just fall right into a void.
Exactly. They fall directly into a void. This creates a systemic disincentive to work. The structure of the system is explicitly telling that parent that improving their financial situation by earning more money will result in losing their ability to see a doctor.
So, what does this all mean? When you combine all of these elements, you see a system built on bureaucratic hurdles that actively prevent early intervention. Mr. Darius pointed out that healthcare relies on relationships built on trust. Yet, the policies governing the system reflect a profound lack of trust.
This raises an important question about how we treat both patients and physicians. Take step therapy, for example.
Oh, step therapy. Yeah.
Step therapy is an insurance practice that forces a patient to try a cheaper, older medication and prove that it fails to work before the insurer will cover the newer, more effective medication the doctor actually prescribed.
Which is wild. It basically tells the doctor their clinical judgment is not trusted.
Exactly. You combine that with endless prior authorizations for standard tests and punitive work reporting requirements for patients, and you create massive friction in the system.
Exactly. When a patient has to fight through prior authorizations or when they avoid care because they fear the high copays, they don't simply stop being sick, they just wait.
Right. The disease doesn't take a break.
No. The disease progresses in the background until their condition deteriorates to the point where they require emergency care. The bureaucratic friction drives patients away from the preventative care that is cheap and funnels them directly into the emergency room where care is astronomically expensive.
Which brings us to how the witnesses proposed fixing this funnel. If the current system forces people into the emergency room, how do we intervene earlier?
Right. What are the solutions?
Well, the hearing highlighted very specific on-the-ground innovations happening right now in medical education and technological deployment. Dr. Mark Kaufman, the Dean of Academic Affairs at the Lake Erie College of Osteopathic Medicine, or LECOM, he detailed how they are changing the very foundation of how we select future doctors to fix the rural access issue.
This was fascinating. Normally, gaining admission to medical school is heavily dependent on a single standardized test, the MCAT.
Right, everyone knows the MCAT.
Yeah. But LECOM recognized a severe national shortage of primary care physicians, especially in underserved areas. Relying purely on standardized testing wasn't solving the distribution problem. So they developed an academic index score.
Which is a totally different approach.
Yeah. Instead of just looking at a test score, this alternative pathway measures a student's community ties, their grit, and their academic performance in specific programs to recruit students directly from rural and underserved communities.
And there's a good reason for that.
Yeah. Why does measuring these traits matter? Because LECOM's data proves that students recruited this way are 5 times more likely to return and practice medicine in those same rural communities after graduation. They are intentionally engineering a workforce designed to go where the need is greatest.
And we are seeing similar targeted innovation to circumvent access barriers in cancer detection, too. Dr. Patrick Hulu, the president and CEO of Moffitt Cancer Center, detailed their community outreach programs. Instead of waiting for high-risk patients to find transportation and take a day off work to travel to their specialized facility in Tampa, Moffitt is deploying mobile lung cancer screening vans directly into communities.
That is so smart.
Yeah, they drive these vans straight into church parking lots and community centers to find smokers and screen them on the spot. These vans are equipped with low-dose CT scanners that can perform a highly detailed scan in just 20 seconds.
But wait, didn't Dr. Who mention that even with this incredible mobile technology, they run straight into an administrative wall?
They absolutely do. This is a perfect example of the unintended consequence of bureaucracy blocking innovation. Because insurance companies require prior authorizations for these CT scans, the mobile unit cannot simply pull up to a church, identify a patient at high risk, and scan them immediately.
That's so frustrating.
It is. The medical staff has to initiate the authorization paperwork, force the mobile unit to pack up and leave, and then come back a week later, hoping the authorization cleared and the patient returns.
And I bet a lot of them don't come back.
Exactly. In that waiting period, they lose a significant number of patients who simply cannot make it back to the parking lot a second time. It entirely defeats the purpose of a rapid mobile intervention.
Despite those bureaucratic hurdles, Moffitt is pushing the boundaries of biological research, specifically regarding nutrition. Dr. Hu discussed the Pearl Research Kitchen at their facility.
Yes, the Pearl Kitchen.
Historically, nutritional research in cancer has been frustratingly inaccurate because it relied on patient memory. Researchers would ask patients to fill out surveys trying to recall how many servings of fish or vegetables they ate 3 months ago. That is a notoriously unreliable way to gather hard scientific data.
The Pearl Kitchen changes the methodology entirely by conducting precise, controlled feeding studies. They measure exactly how specific dietary interventions stimulate the patient's own immune system to fight cancer.
Like keto, right?
Yeah. For example, they look closely at ketogenic diets and targeted fasting protocols. Cancer cells generally rely heavily on glucose sugar to survive and multiply. By placing a patient on a strict ketogenic diet, researchers are essentially starving the cancer cells of glucose.
That makes total sense.
Meanwhile, the patient's healthy cells and immune cells adapt to burning ketones for fuel. They are investigating the exact biological mechanisms of how diet can starve a tumor, replacing that memory-based guesswork with rigorous biological measurement.
Here's where it gets really interesting regarding technology closing the geographic gap. To solve the access disparities in specialized cancer care, Moffitt is digitizing their entire pathology department.
This is a game changer.
It really is. Think about what this means for a patient living in a remote rural town. Usually, a local hospital might struggle to accurately diagnose a rare or complex cancer because they don't have subspecialists on staff. But with digital pathology, that rural hospital can take a tissue slide from a biopsy, scan it at incredibly high resolution, and transmit the digital file instantly to the specialized experts at Moffitt. The rural patient gets the benefit of a world-class diagnostic team analyzing their tissue without ever having to travel hundreds of miles from their hometown.
If we connect this to the bigger picture, you can see the roadmap for modernization emerging from these testimonies. It is a multi-pronged approach. You have the structural transformation of medical education. During the hearing, there was a discussion about the Trump administration's pledge to ensure medical students receive at least 40 hours of dedicated nutrition training.
And just to interject quickly for you listening, as a rule, we look objectively at the structural policies mentioned in these hearing transcripts, regardless of which political administration proposed them, so we can understand the shifts being debated.
Exactly. The goal of that policy proposal is to ensure doctors actually have the foundational knowledge to discuss food as medicine rather than just relying on pharmaceuticals. When you combine that educational shift with the utilization of new technologies like the digital pathology we just discussed, or the artificial intelligence and robotic surgical tools Dr. Reckitt noted, which allow for faster surgeries and drastically reduced hospital stays, you start to see a path forward.
Yeah, it starts coming together.
These aren't just isolated medical advances. They are the necessary structural changes required to solve the rural access disparities and the financial unsustainability of the current $5.3 trillion sick care model.
As this committee hearing concluded, the process of formalizing these potential solutions moved to the next step. The committee officially adjourned, and the members were given 2 weeks to submit written questions to the expert witnesses.
Right, for the record.
Yes, those questions, along with the detailed written answers provided by the experts, will be entered into the formal hearing record. That official record is what will be used to guide and shape future legislation regarding healthcare modernization in the United States.
Before we wrap up today's exploration, there is one Final, incredibly provocative piece of information from this hearing that you should carry with you.
Oh yeah, this part was wild.
When discussing the future of prevention and looking for root causes, Dr. Hu briefly mentioned the institution's ongoing research into the oral microbiome.
He noted that the specific bacteria found in gingivitis, which is common gum disease, is the exact same bacteria they are now discovering deep inside Alzheimer's plaques and in brain tumors.
That is just terrifying.
When gums bleed, it creates a direct pathway for this bacteria to enter the bloodstream, bypass normal defenses, and travel directly to the brain. It leaves you with a profound, almost unbelievable thought to ponder. Preventing some of the most devastating, system-bankrupting chronic diseases in America might literally start with something as simple as you taking the time to floss your teeth.
Right.
It brings us right back to the beginning. Sometimes the most powerful medical intervention isn't a better way to rebuild the engine, it's simply taking the time to check the oil.